Hi, I'm Loretta Nastoupil from the University of Texas MD Anderson Cancer Center, and I'm at the 2019 International Conference on Malignant Lymphoma in Lugano, Switzerland. It's been a fantastic conference. So we started the conference with a plenary session covering the robust study in the Mayo Eastern Cooperative Group collaborative study looking at the introduction of lenalidomide into R-CHOP for untreated diffuse large B-cell lymphoma patients. So a couple of key points. The study designs were different in these two trials, which may reflect differences in outcomes. And what I mean by that is the ECOG study enrolled all comers, including GCB and non-GCB patients. They did undergo gene expression profiling, and once patients were identified to be of GCB cell of origin, those patients were deemed ineligible for the trial. But what that resulted in is a much shorter time to treatment initiation of about 21 days. On the flip side of that, the robust study took patients prior to starting treatment. They actually determined cell of origin, whether it was ABC or GCB, and the ABC patients were deemed eligible, and that resulted in a delay in initiation of treatment. There are other key differences in terms of dosing of the lenalidomide and duration of treatment, but I think it's important to note that the ECOG study was a positive study. The addition of lenalidomide actually led to an improvement in outcomes, whereas the phase 3 randomized robust study actually was a negative study. So unfortunately, that means we don't have a practice-changing abstract coming out of the plenary sessions, but what it does enforce is that we have to rethink clinical trial design, particularly in untreated large cell lymphoma, so we can get patients on treatment more rapidly, and we don't over-select for good patients, therefore the control arm performs very well. So more trials are needed, and I think targeting the microenvironment or immune modulation in large cell lymphoma should still be studied. Along the lines of large cell lymphoma, Jason Weston presented some very interesting data looking at the SMART start, where he introduced lenalidomide in combination with ibrutinib and rituximab for 6 weeks in untreated large cell lymphoma patients in the absence of chemotherapy initially, which is quite dynamic. The rationale behind that is that lenalidomide and ibrutinib should be synergistic in terms of synthetic lethality, and he actually had a response assessment done prior to the introduction of either R-CHOP or R-dose-adjusted EPOCH, and what he showed is about 36% of patients had a complete response to the targeted therapy only, and then all those patients remained in a complete response at the end of the 6 cycles of chemotherapy, and there were patients who had a partial response to the targeted therapy converted into complete responses. So the response rates were fantastic. It is a single-center, single-arm study, but it does introduce the idea that we need further study, and particularly lenalidomide or IMiD-based therapy in large cell lymphoma is not dead. Also at this meeting is the L-MIND data, is looking at an anti-CD19 antibody combined with lenalidomide in relapsed large cell lymphoma. These are not chemo-refractory patients, but the outcomes are quite good and potentially even more favorable than what we see with lenalidomide and rituximab, albeit it's a non-randomized study. But again, an interesting mechanism or target, CD19 in large cell lymphoma, probably going to move into earlier lines of treatment. In follicular lymphoma, we saw the introduction of a PD-L1 antibody into the R-squared backbone, and those response rates were phenomenal. We don't see a significant increase in toxicity, suggesting again, if we can harness the immune system to target the lymphoma cells, you can have good outcomes. We see good outcomes with lenalidomide and rituximab, which was highlighted by John Leonard with another presentation on the AUGMENT study, which led to recent FDA approval of lenalidomide and rituximab for relapsed marginal zone and follicular lymphoma patients. He reported on the POD24 patients, which we know is a poor prognostic sign in follicular lymphoma. And interestingly, those patients didn't do worse in his study than the patients who had not met the criteria for POD24, suggesting that yes, lenalidomide-based treatment in follicular lymphoma is an effective strategy and can be considered for patients with early relapse disease, suggesting that the SWOG S1608 is an important study and should be prioritized in terms of those early treatment failure follicular lymphoma cases. In mantle cell lymphoma, we saw zanubrutinib, which is a second-generation BTK inhibitor for relapsed mantle cell lymphoma. This was a Chinese cohort, but the patients had very high response rates, and the toxicity may be more favorable than, for instance, ibrutinib, meaning they saw reportedly no incidence of atrial fibrillation, and the rates of grade 3 or higher bleeding or bruising was quite low. And lastly, I'll discuss the abstract presented by Pierluigi Zanzani looking at the introduction of brentuximab vedotin in combination with nivolumab for relapsed refractory primary mediastinal large cell lymphoma. Response rates were quite high, which is quite intriguing because pembrolizumab is FDA approved right now for the treatment of relapsed primary mediastinal large cell lymphoma based off of a response rate of 40%. And we know that most of these patients have CD30 expression, so it's not a leap to introduce brentuximab vedotin into a PD-1 based therapy, but the response rates were quite high and suggested there might be some synergism. So that was a very interesting single-arm phase 2 study that might potentially be practice changing.